I'm a GIRFT lead in diabetes, and I'm particularly interested in inpatient diabetes care, hence the focus on perioperative care as well. By way of introduction, I'm going to actually give you a little bit of background around the issues facing people with diabetes coming in for surgery, and that's going to be both elective as well as the emergency surgery. Following my presentation, we've got a recording of a webinar which we did with Cath Robinson, who's a consultant anaesthetist in Manchester, and she's also been the lead for the perioperative pathway, the IP3D, which I'll tell you a little bit about. So she'll come on last as a video. So as a background, there are about 250,000 operations taking place in the UK in people with diabetes, and about 1/3 of those are emergency surgery. Now, we know that people with diabetes, irrespective of the condition, whether it is medical or surgical, have a longer length of stay. So you can see in medicine it's a couple of days, elective surgery is 3 days, and emergency surgery is even further, 4 days. And I'll show you later that there is a significant variation. We know, in addition to the longer length of stay, there's an increased mortality and readmission rates. You can see the mortality here, diabetes compared to non-diabetes, and the morbidity for various things, including particularly infections, is increased. These are partly related to things like they have comorbidities, cardiovascular and renal disease. However, poor diabetes care is one of the major factors. You can see that hyperglycemia in red is associated with poorer outcomes in people with diabetes. But not only hyperglycemia, but hypoglycemia, and you can see length of stay increases and mortality increases in hospitalized patients with hypoglycemia. Can we do anything about this? Well, better glycemic control. This is the original work from Perez, who's well known for work in inpatient diabetes care. He was able to show that using a basal bolus regime compared with a sliding scale, in America, sliding scale is a sliding scale of bolus insulins, short-acting insulin. So basal bolus compared with sliding scale, and you can see the outcomes are significantly better by better diabetes control. A few facts about inpatient diabetes in general. 1/5 of patients has an episode of hypoglycemia while in hospital. 1 in 50 require injectable rescue treatment, and that's from severe hypo, such that they're almost unconscious or are unconscious. And 1 in 25 people with type 1 diabetes develops DKA in hospital, which is a really significant number. And most often, this poor diabetes outcomes are related to diabetes mismanagement. And this tends to be more common on the surgical wards, where the experience of diabetes management is perhaps less in the junior staff. So a number of years ago, in fact, 13 years ago, we wrote the Joint British Diabetes Society's guidelines on the perioperative management of diabetes, which I'm sure many of you will have seen. And that takes you from referral from primary care all the way through to discharge. Unfortunately, despite it being in place and being recognized by the colleges and so on, it had not been implemented in many trusts. We prompted NC Pod to do an assessment of perioperative diabetes care, and the report, the High and Lows report, published in 2018, found that 65% of trusts had room for improvement in their clinical and or organizational care. In 2017, I wrote this report for Diabetes UK, Making Hospitals Safe, and recommended that all hospitals should have a perioperative diabetes team with representation from surgery, anaesthetics, etc. And we repeated this and the recommendations of NC Pod in our GIRFT report in 2020. As you will know, CPOC was commissioned by the Academy of the Royal Colleges following that NC-POD report to look at perioperative diabetes care, and they published this guidance in 2021, which really reflected what we had it was an update of what we had from the JBDS guidance, and this was really a very multidisciplinary guideline, which included many of us from the JBDS document. So that brings me to this study, which I just want to share with you. Again, this is about elective surgery. This is facing the difficulty of implementing such pathways. We scratched our head, myself and Emma Page, who works with me in GIRFT, but at that time she was working with me in Ipswich. We scratched our head and thought, how can we influence better surgical care for people with diabetes? And within our trust, it was felt that there was not a big issue, but we were able to point out a number of cases where things went not terribly well, and were able to have some influence as a result of that. Now, this shows you the length of stay for many of our surgical specialties is significantly greater than people without diabetes, and benchmarked against other trusts, we weren't doing so well. We also had patients coming in as day cases who had a high percentage compared to people without diabetes having to stay in as a result mainly of problems with their diabetes management. So this is the innovative pathway we came up with. And this was called the Improving Perioperative Pathway for People with Diabetes, the IP3D program. And the key to this was to empower the patients through the use of a perioperative passport, which informed them of what sort of care to expect, what to do with their medication before surgery, what sort of blood glucose control is good for them, particularly when in hospital, and things like asking questions of their care. For example, as soon as you're able to eat normally, if you're on an intravenous infusion, it should be discontinued. If not, ask why not. Patients found this really useful, and initially the staff were a bit reluctant to use this and felt that it'd be challenged. Actually, they learned an awful lot from this. That included the pre-assessment staff as well as the staff on the wards. The other innovation was to appoint a perioperative DSN, and we did this from our charity funds with the understanding that if this demonstrated improved outcomes, then this would become part of the anaesthetic and surgical directorate to continue the funding. One of the key things was to appoint a nurse from a surgical background rather than us impose a diabetes specialist nurse. We trained this nurse up. She was well known to her colleagues and very influential. So she supported the introduction of the pathways, education of patients, and education of staff. Ongoing now, there are new guidances to come out. There's the use of subcutaneous pumps and flash glucose monitoring and closed loops. This individual or these individuals, the perioperative nurses, are really essential for the changing face of diabetes, for example, stopping SGLT2 inhibitors. Our results were a significant reduction, 1.5 days in length of stay, significant reduction in post-operative complications. It was really well received by the patients and well received by the staff, resulting in improved staff knowledge and confidence. So that was one trust. The question is, is this a one-off thing related to Ipswich Hospital and, my influence, for example, in the hospital? So we were able to get funding from GIRFT to pilot this in 10 other trusts. And this is the result. There's a almost 1 day reduction in length of stay across the 10 trusts. There was a 63%, that was elective care. This 63% reduction in length of stay for people in day care surgery. There was a 58% decrease in wound healing, delayed wound reduction in delayed wound healing and infection, and a 71% decrease in diabetes-related complications, hypoglycemia and hyperglycemia. So it was really very successful. And if you're interested, I think Emma will put in the chat her contact details. But what we are doing is running this out to any trust across the country who would like to join this IP3D program. We've published this, and Emma will put this in the chat, the paper, and it's really important that I thank all the perioperative DSNs and the surgical champions who were involved in that project. Much to our surprise, we were contacted by an American organization who'd seen the project and asked us to apply for an award, which we won. So now this is, as December last year, the number of places which have adopted the IP3D program in the blue triangles, and those who have expressed an interest in adopting it, and a number of these have turned to blue triangles. So on to what the title of today's topic is emergency surgery. And I want to show you the variation in length of stay. GIRFT is all about reducing variation. And you can see the length of stay fractured neck of femur, which we take as an index as emergency surgery. This is the commonest emergency surgical procedure. There's a threefold variation from nearly 40 days to 12 days from the top to the bottom. And the variation is really interesting. So this is a trust with two sites of identical bed numbers and the same populations. In site A, the length of stay is nearly 23 days, compared to the non-diabetic length of stay of 18 days, which is plus 4 to 5 days. In trust B, the length of stay is only 14 days, and actually that's better than the non-diabetes population. So very significant variation. This must relate to practice. So with regards to guidance and pathways for emergency surgery, there are no such guidance available, not on a national basis. And as you realize, emergency surgery has a number of specific issues, and I've only put down a few here, but acute illness significantly impacts on diabetes control. Medications such as SGLT2 inhibitors and metformin are still on board. You can't stop them 3 days before, or 2 days before, as advised. And of course, there's a limited time to access specialist diabetes care because things are moving quite quickly. So we felt that we really did need to produce a guideline around emergency surgery, but we did feel that this was going to be quite difficult and quite complicated. So what we did was got together an expert working group, and I'll show you the working group in a minute, with various specialties involved and various professionals, so diabetes specialist nurses, pre-op nurses, pharmacists, anaesthetists, surgeons, and diabetologists, etc. We had trusts of varying sizes represented, and the idea was to follow the whole patient journey and look at the potential things which could go wrong, the various steps, and see what we could put in place to actually make sure that things were done correctly. We used evidence where it was available, but as you probably know, there's not an awful lot of evidence. So therefore, we used best practice and very much consensus guidance. We got feedback from colleagues locally, but also we got national feedback from CPOC, the College of Anaesthetists Diabetes UK, and the Association of Clinical Diabetologists. So we had nearly 60 individuals involved, including individuals from CPOC and surgical representation. And so that's how we developed our guideline, which looks like this. Now, this looks really complicated, But actually, I'm going to pass you over to Cath now. And as I said, she was recorded when we did this webinar, and she describes this absolutely beautifully.
I'm Cath Robinson. I'm from Manchester Foundation Trust, and I'm going to take you through the new GIRFT Diabetes Emergency Surgery pathway now. So, as Gerry said, many of us were involved in the GIRFT IP3D project before developing this pathway, and we'd seen some real improvements for our patients with the IP3D study, but it had entirely focused on the elective pathway. Now, we know that we've got good guidance out there from CPOC that also includes emergency surgery. But we found that universally within our group, we hadn't done as well at implementing the points of these guidance for our emergency patients as we had for our electives. So we tried to unpick some of those reasons why we weren't managing to do this. Now, I know we've got a lot of diabetes experts on the webinar today, and you may not agree with my first point, but just speaking as a non-diabetes specialist, it can feel difficult to keep up to date with diabetes. You seem to come up with a new, utterly unpronounceable diabetes drug every month or so, and we just about get our heads around what we should be doing with subcut insulin pumps in the perioperative period, and then you come up with closed loop systems, so it can feel tricky. We know that working in silos has been reported as an issue in perioperative diabetes in general for many years now in various reports. It's very easy for us all to focus on and hone in on our own individual section of that patient journey from admission to discharge. There's multiple different parts of that pathway with lots of different staff members involved, and trying to keep an overview of that whole pathway is really important in the overall care of that patient. Another point that's frequently fed back to me in our trust is that it can be hard to easily access the information that you want when you need it in a hurry. So we've locally got some perioperative diabetes guidelines, as I'm sure you have, but it runs to 30 pages. There's a lot of information to impart. So my colleagues say to me, well, I've got 6 patients on the emergency list that I'm trying to see. I can't easily get to that right bit of the information that I want. I want something shorter and more succinct. So we wanted to try and solve some of these problems. So our main aims were, first of all, just to map out that process, that pathway for the person with diabetes who requires emergency surgery, right from presentation at the hospital to their discharge. And then try and give clear advice at each point to try and make it as easy as possible for us all to do the basics well. So I'm now going to go on to show you the overall pathway. So this is the pathway in its entirety. And now we've promised to try and make things easier for you, and you think we've lied now, but we haven't. I want to show you the pathway in its entirety first, just so you can see all the sections that we've broke it down into. But it's not designed to be used like this. And GIRFT are looking at making this into an interactive pathway so that you can then hone in on your area that you need to look at. So, for example, if you work on the surgical wards post-operatively, you can then find that column over on the right that's particularly telling you and giving you little reminders and tips about what to do in your area. The sections that we cut it down into were things that we should be thinking about on referral, on arrival at the hospital. What should we do once we've made a decision to operate? Things to remember in our pre-op assessment and the surgical listing of these patients. What should we be doing once that patient's in theatre? What things should we be doing in the post-operative phase, and then planning for discharge for these patients? What I'm going to do now is just take you through some of the key points on each of these flows in the pathway. So we'll start with referral. So for this patient who presents probably to ED or to the surgical admissions unit, the first point that we've emphasised is to think about DKA early and to test some blood ketones, particularly if that patient with diabetes is presenting unwell. We want early medicines reconciliation, And we also want the surgical decision makers involved early. We really don't want this patient seen by a very junior member of the surgical team and then sat waiting for hours, nil by mouth, not sure if they need surgery or not. We want to try and minimise that period of fasting, so we want to have that decision made early. We'll check that the CBG is in the target range and take action if it's not. So once the decision that an operation is required has been made, what should we be doing then? So we've just looked at and picked out the pre-op investigations that we require specific to diabetes. Obviously, they may need other investigations depending on their other comorbidities and surgically what's going on. So what we want for their diabetes: ECG, renal profile, lactate and ketones. Now, we're great at doing ECG and renal profile. Everybody gets those, don't we? We're not quite as good at doing lactate and ketones. And in particular, all in the CPOC guidance, all patients presenting for emergency surgery should be having that metabolic status assessed. We should be doing these pre-op ketones on these patients. In our trust a couple of months ago, we had a patient in the recovery room after fairly minor surgery, emergency surgery, unwell, very difficult to pick out what was happening, quite vague symptoms, and eventually they checked ketones and realised that she was in euglycemic DKA. It was a difficult diagnosis to make at that point. How much easier if we just get used to checking blood ketones in everyone who's presented and it's presenting for emergency surgery and has diabetes, and then we can either rule it out, we've got normal ketones, or we can find it and treat it at that stage. HbA1c, we're great now at checking this for our elective patients, aren't we? And making sure that we've got an up-to-date HbA1c within 3 months of surgery. We do it rarely for our patients having emergency surgery, and I can see what the surgeons and anaesthetists are thinking. Well, we're going to do this surgery anyway. What's the point? You know, how's it going to change things? Well, it won't for that acute phase, but certainly afterwards, if we've done that HbA1c and it comes back and it's high, we've got an opportunity then to make changes to the diabetes management for this patient and get specialist help from the diabetes team if we need it. Again, the next point, we need to make sure that these patients get the appropriate advice about what they should be doing with their pre-operative diabetes medications, including their insulins, according to that CPOC advice. You're probably all familiar with the two tables on how to adjust insulin and non-insulin medications in the pre and peri-op period. Again, we've got really good at doing this for our elective patients. We've had lots of education with our pre-op nurses, and and I'm sure you're all giving written information for your patients in the elective setting, a perioperative diabetes passport if you're using them. But for the emergency patient, this is a little bit of a black hole for us. We haven't had the same emphasis on this teaching for the wards on the surgical admission units or the surgical wards, and it's not done as well. But I think an even bigger group where we're missing this are patients who are discharged to then come back on an urgent list. This might be urgent gynae, a trauma list, a plastics list. And we're just trying to find out who is giving them this advice, if anybody. Is the trauma nurse coming and giving them some written advice? Are we leaving it to the surgical team to do this? And again, it might be something you want to think about in your own trust about how this is happening or whether it is at all. There's a reminder in this column to withhold your SGLT2 inhibitors for these emergency patients once they're admitted. Another thing that is often missed is if we've made that decision for a patient to go on a VR-III, have we reduced their basal insulin to 80%? If your patient is on an insulin pump, a CSII, have we made sure we've got an alternative source of insulin before we've discontinued that CSII? And then when we think about the pre-op assessment and the surgical listening, listing, we should think about whether we can do this as a day case. We don't think about this as often as we should do for emergency cases in general, but also for patients with diabetes. So in the NCPOD report, 9% of hospitals wouldn't offer day case surgery for patients if they had diabetes. So we should be, on both counts, thinking about whether these patients with diabetes can have this as a day case. Have we clearly noted on the patient's records that they've got diabetes, what type it is, and also on the theatre list? Because if it's not clear on the theatre list, then we've got no chance of succeeding with the next point, which is to try and prioritise that person with diabetes for surgery and minimise periods of prolonged fasting. We want to get them back on their usual diabetes regime, eating and drinking as soon as we possibly can. Now, we can't always do that, can we? If we've got a AAA waiting, then we can't always prioritise the person with diabetes who's waiting for less urgent surgery. But if we've got 2 cases of similar urgency, then we should, if we know, be trying to get that person with diabetes in first. So what about when we get the patient to theatre? Now, I really wish we didn't have the top box in this column because I wish we didn't need to. But this has certainly been a problem in our trust, and on discussion, it had happened in almost all the trusts that were involved in developing this pathway. So if we've got a patient who's been put on a VRII, it's just to remind the staff that they shouldn't be discontinuing this, not discontinuing the IV insulin or the IV glucose containing fluids on transfer between the ward and theatre. Now, we need to ensure that we're discussing the fact that this patient has diabetes at the team brief and the patient sign-in. So this is something we do as a team in the theatre so that all staff are aware of important things about this particular patient and their surgery. And then NCPOD found if you even just mention that the patient has got diabetes at that team brief, then you improve the appropriate frequency of CBGs done intraoperatively, and you improve appropriate management of CBG in the recovery area afterwards as well. And that's just sharing that knowledge that the patient's got diabetes, so all the team know and may prompt, us as the anaesthetist if we have forgotten to do that next CBG. There's advice in this column for the appropriate CBG frequency in the perioperative period, and also a reminder that we should be adhering to ERAS principles. So that's enhanced recovery after surgery, and that's where we want to try and optimise multimodal analgesia and antiemetics so that we try and minimise the risk of post-op nausea and vomiting, again with that aim of getting that patient eating and drinking and back on their usual diabetes regime as soon as possible. Now, if I could only pick one thing out of the whole pathway to implement, it would be this next point. So at the sign out, again, this is a point at the end of surgery where the whole theatre team with the anaesthetist and the surgeons and the scrub team and anaesthetic practitioner will discuss any relevant points for this patient. Now, at this point, we should be saying, have we prescribed insulins for this patient post-operatively, if they're on them, and all appropriate diabetes medications? And this should be done before. If it's not done at this point, then we need to highlight one person who's going to do it out of the surgical or the anaesthetic team and make sure that's done before the patient leaves recovery. We also need to be communicating our post-operative diabetes plan to the recovery staff and then onwards to the post-op ward staff as well. And there is a link on the pathway on the GIRFT website to a suggested handover that you could adapt to your own trusts. What sort of things do we need to be handing over to recovery and onto the ward? Well, we need to tell them what type of diabetes this patient has got. And have we kept that blood glucose within range, preferably within 6 to 10, but 4 to 12 may be acceptable in certain circumstances? And if not, what treatment was required for that hypoglycemia or hyperglycemia? We need to let the staff know what we've given. Again, we've got another prompt. Have all those usual insulins and diabetes medications been prescribed post-operatively? But we've also got a reminder in there just to withhold the SGLT2 inhibitors until that patient's well, drinking and on a full diet. Also, another prompt, we should be testing for ketones daily in these patients until they're eating and drinking normally. We also give the advice on how often we want that CBG frequency until they're eating and drinking and back on their meds again. And for patients who are on a VR-III, have we prescribed that basal insulin, and have we done it at 80% of their usual dose? Have we given some instructions for taking down the VR-III? And here we've given option 1, which is kind of the generic advice for taking down the VR-III. So the patient's well, they're eating and drinking, their ketones are normal if they're type 1. We've given some subcutaneous insulin before taking down that VR-III. And also, if they're on an insulin pump and we are going to restart them on that CSII, has that been running for an hour before we take that VR-III down? If your anaesthetist has some alternative instructions or additional instructions, and then space for that to be included as well. And now we're going back to the post-operative ward. What do we want the nurses and staff and surgeons to be doing there? Again, just a reminder about how frequently they should be doing their CBG. Has that insulin been prescribed in a timely way and administered at the right time? If we're stopping the VR-III, again, a prompt for your nurses, have they given some insulin first? They should be checking those daily capillary blood ketones, and also a daily foot check for these patients with diabetes while they're an inpatient. And now let's go back and look at that HbA1c that we took preoperatively. Is the result back? Is it high? Do we need to get some specialist involvement from the diabetes team? And we should be thinking about now whether we're going to need a district nurse referral. So now we'll get on to discharge planning, and there's links on the pathway to the diabetes discharge checklist and discharge documentation that we could be using. Have we made sure that all the right people know, particularly if we've made any medication changes, the person with diabetes themselves or their family or carer, and also their GP or their routine diabetes care provider? And then we've got a couple of messages that aren't just for one stage of the pathway, they're for the whole pathway from admission to discharge. And these are to never leave a person with type 1 diabetes without insulin, so that we're teaching all the staff members at each stage this important point. And we should be measuring capillary blood ketones if the person with diabetes becomes unwell or has persistent hyperglycemia. If I'm teaching on the diabetes emergency surgery pathway, absolutely, we want to teach that specific part for those staff members. So if I'm teaching the recovery staff, say, we're going to hone in on that theatre and post-operative stream there, but also show them where their section comes in the overall journey of that pathway. So that was the easy part, mapping out the process from admission to discharge, and hopefully we've got useful advice at every stage. Now the difficult bit is implementing this, trying to make lasting changes now using this emergency surgery pathway. So we're going to collect some data before and after implementation. And we've got several trusts who've been involved with the emergency pathway who are going to collect that data. And the things we're looking at so far are in the blue box on the right. So have we checked those pre-op capillary ketones in these emergency patients? Have we made sure their SGLT2 inhibitors have been stopped? Was it clear on the emergency list that this patient had diabetes? Now your list might be different for your trust. You will know what you're good at in your trust, and you'll also know probably where you're not quite as good, and maybe that's been maybe you know that from incidents that are reported to you, and they tend to be in a certain theme. So you can make up your own areas that you need to aim your QI at. Staff education is going to be key as ever, but you can see there's a long list of people that we need to get to there, different staff groups. Now, if you work in a trust like mine, this is the largest trust in the UK. We've got 28,000 employees in our trust. And to try and educate all the people we need to get to is really difficult to access all these people. If I just want to speak to the anaesthetist, we've got over 300. So as well as face-to-face teaching, we're planning in Manchester a series of short videos and then specific to that particular role, and then working with the educators in that area to try and get as many of their staff to watch that educational video as we can. But as well as education, if there's anything we can do to make parts of this automatic, so if you, for example, use an electronic patient record, we use Hive in Epic in our trust, then maybe we can actually try and make that work better for us and the emergency pathway. So one of my colleagues is looking at just pulling it through onto the emergency list automatically, whether that patient's got a diagnosis of diabetes or not, and making that clearly visible. And there's also working on an electronic handover from the anaesthetist to recovery to the ward staff afterwards, and just to make sure that we're prompted to put all that right information in. It may be that you need to look at some of your infrastructure and equipment. So for us, we've obviously talked about checking capillary ketones at various points during this pathway, and we had to go back and check that we actually had ketone meters everywhere that we're going to need them prior to rolling out this pathway. Now, I think this is going to be almost impossible unless you've got an interested and motivated MDT involved in this. You need good communication and cooperation between diabetes, anaesthesia, peri-op medicine, your surgeons, your ward staff. It all need to be involved. You can't just do it on your own. And if you're lucky enough to have a perioperative DSN, then that can really be some of the glue that can hold this together. So we talked about working in silos and us all just looking at our own very narrow part. But the perioperative DSN is involved right from admission up to discharge or even beyond for that patient, and can be that overarching, have that bigger picture view of this patient and their journey through the hospital for emergency surgery. So just a summary, with the pathway, we've mapped out each stage of the process and given clear advice at each stage for these people with diabetes requiring emergency surgery. It's all on a single sheet, and you can hone in then on your particular area for a quick reminder of what you should be doing for these patients requiring emergency surgery. We need to make it easy to access. You can access this from the GIRFT website, and then there's links to the relevant parts of the CPOT guidance, so you can see that those tables at a glance are what you should be doing with their perioperative diabetes medications. So I hope that we've gone some way to one of our main aims, which was to make it as easy as possible to do the basics well for this group of patients. Thank you.